So what we're going to be discussing is a topic called pro-resolution, and these pro-resolution mediators are available under ProResolve, and this was recently launched in Europe. It's been available in the United States in an online store for a couple of years, and I've been using these in my practice probably 5 or 6 years, and using it with professional athletes for a little bit longer. The reason why it's so successful, and I go back to this as one of the main things that I use in working with athletes, is because a chronic inflammatory state is a very common occurrence when you're looking at athletes and treating athletes and how you recover from injuries, and also how you make it through the course of an entire season, especially in sports like hockey or in the NBA, where injuries are just part of the game. There's evidence of, and I'm kind of starting with the brain first, but there's evidence of inflammation being a big part of the process in concussions and traumatic brain injury, and I don't think this is really argued anymore. There was a point in time where this was sort of discussed as a possibility, but at this point, I think it's fairly clear that inflammation is a major player in what happens in concussions and in brain injury. And if you look at brain injury starts with a primary phase, which is called coup, contra coup, and axonal shearing. So the brain, basically, in this slide, you'll see that the brain is slapping against the skull in the helmet, which is showed at the top here for American football. This results in the release of an excitatory neurotransmitter called glutamate. This will cause an excitation of the membrane. You get an influx of calcium into the cell. You also have axonal damage or axonal shearing, and this results in more membrane permeability. And the result of that is that the body will attempt to increase its metabolic rate initially to try to respond to the injury. And so this hypermetabolic state is happening with the goal of trying to create more ATP for energy storage. But it often can't keep up. It causes the calcium influx will cause mitochondrial dysfunction, so the nuclear power plants don't work properly. It increases oxidative stress and damages the mitochondria, but also leads to a hypometabolic state. So you're not able to keep up with the demand metabolically to be able to keep glucose utilization up to par with being able to support the healing process. And so once somebody's had an initial injury, until they get to the point where they are recovered from that, they are at an increased susceptibility to repeat injury, which would be the second impact syndrome that you hear discussed. So while oxidative stress is happening, you also have an upregulation of inflammation. So you have your immune cells in your brain, your microglia, which become activated, recruit macrophages, and this causes cellular damage to be present. And particularly when you have a lot of oxidative stress that has affected the cell. So you have accumulation of this toxic waste attaching to fats, which is called lipid peroxidation. You have damage to DNA, which can be measured. There's a marker called 8-hydroxy-2-deoxyguanosine that you can check in the urine that would look at DNA oxidative stress. And so you can see when somebody is in this state of cellular damage after an injury, and the ultimate result of this is apoptosis or cell death. So this is after a concussion and TBI. And there's a lot of overlap that happens between TBI and PTSD, and also in states of chronic sleep deprivation. So the symptoms overlap, and there's sometimes it's hard to tell which one is which and what's going on. And when you look at the studies that are done on PTSD, you'll see we just listed a couple of them here, where they looked at inflammatory immune markers and cytokines in people who had PTSD, and they found elevated levels of these. It's not surprising to see this, as that affects what happens with neurochemicals and changes the tryptophan pathways, and there's a whole bunch of chemical changes that happen within the brain in all of these states. So understanding that inflammation is present in these states, and why do we have inflammation, and why would inflammation be considered beneficial? Well, it's essential. If inflammation is typically supposed to be a natural, well-coordinated process of protecting the organism in response to an infection or tissue damage. And the cardinal signs, or the main signs that you'll see in an acute inflammatory state, are going to be pain, redness, and swelling. So you'll get heat, you'll get edema, immune cell accumulation, mainly in the form of neutrophils. And the role of inflammation is to eliminate the initial cause of cell injury and remove any necrotic tissue, and then initiate the process of repair. And so the way that I think of this in very simplistic terms is that if I have a light bulb that's burned out, I've got to take the old light bulb out before I put a new light bulb in. So inflammation is taking the old light bulb out. And so when I'm discussing that with athletes, trying to explain to them what inflammation is supposed to do, that's what I usually use as sort of the example. And so in an inflammatory process, there are what are called chemical mediators, or pro-inflammatory chemical mediators, that are part of this process. And if you take a cell membrane, you'll find that there are omega-3 and omega-6 fatty acids in the cell membrane. You're going to pull omega-6 fats and use an enzyme called phospholipase A2 to begin to produce arachidonic acid. And arachidonic acid then will be converted further through cyclooxygenase or lipoxygenase into these prostaglandins and leukotrienes and thromboxanes. And so in this state, what you're going to see is an inflammatory change that then recruits in neutrophils. So you start to begin the process of recruiting in the immune system to come in and start to clean up this area. And you can see in this diagram off to the right what affects, what medications will affect which enzymes. So phospholipase A2 is affected by corticosteroids. So if you were giving somebody prednisone as an example, you would be blocking phospholipase A2 and blocking this inflammatory cascade, which is sometimes necessary for people. Same thing with anti-inflammatory medications, non-steroidal anti-inflammatory medications like ibuprofen or Indocin, and aspirin. Aspirin works a little bit different. It actually has a different mechanism or effect on the pro-resolution process versus the other anti-inflammatory medications. But the idea is that you're blocking cyclooxygenase so that you block prostaglandins. And so the problem with inflammation is when inflammation is not time limited, when it goes on and becomes a chronic state. And so the end of inflammation happens when we get into a second active phase, which is called the resolution phase. And SPMs, or pro-resolution mediators, allow the return to homeostasis for somebody after an injury, and they promote tissue repair and regeneration. In fact, SPMs are produced by stem cells. And so if you have somebody who, let's say, is looking at stem cell procedures to kind of help with an injury, which is sort of becoming a little bit more common with some of these chronic injuries, SPMs are part of that process of healing. They're released by stem cells and start to promote regeneration and repair. People who lose this ability or are stuck, become stuck in a chronic inflammatory state, have a hard time healing. And so inflammation, again, is an active acute phase, and you have release of chemical mediators that initiate the inflammatory phase, like prostaglandin E2, you can see down on the bottom left there. But you have to have the active phase of resolution that happens at the same time. And these are going to be staggered a little bit in time, but that's what leads to the return to homeostasis and the return to normal, effective growth and repair of tissue. So what led to SPM discovery? Well, in the last decade, Charles Sirhan, Dr. Sirhan, began studying these in Boston or at Harvard, and he found that inflammation resolution was an active process, and that it was driven by pro-resolution mediators, and that these mediators were mainly derived from EPA and DHA, which are in fish oil. So he found that it was possible to measure resolution activity in vitro and use sophisticated cellular assays to do this. And this is something that at some point in time will become available to us, the resolution assays, so that we can measure whether somebody has the ability to produce resolution mediators or not. So what happens if inflammation does not resolve? If inflammation is unchecked and there's no resolution and acute inflammation is prolonged, the result obviously is a chronic inflammatory state, which leads to chronic degenerative conditions. So in a normal situation, if you have a balanced response, and this would be somebody who has a very balanced diet, who is working on sleep, has a balance between omega-3 and omega-6 fats in their diet, is able to control stress, they're not overtraining, they have recovery days. This is somebody that you would see a balanced response. You'd see an injury happen with an onset phase, and then you would see an active resolution phase take place and normal healing happen. And so younger people typically are much better about being able to heal naturally without any sort of intervention. But once you start looking at people who are high performers, who are in a high stress state, or maybe aren't sleeping well, or maybe they're in sympathetic overdrive, so their autonomic nervous system is geared a little bit more towards sympathetic responses. These are people that may have an excessive response and then get into the non-resolving chronic inflammatory state. And it is possible to get people to heal through pharmacological resolution. And that's what we'll kind of begin touching on here. So SPMs will drive the orchestrated process of resolving inflammation. There is a switch from the production of arachidonic acid and that conversion of arachidonic acid through cyclooxygenase into thromboxanes and leukotrienes and prostaglandins. That switch will happen with lipoxins. And so lipoxins would be derived from arachidonic acid, and that mediator class switch then will cause the production of resolvins, protectins, and marresins, which are derived from EPA and DHA. And what you'll see from an immune standpoint is initially you get infiltration of neutrophils that happens with swelling and edema. Those neutrophils then begin to be replaced by pro-inflammatory macrophages. And then after the production of resolution mediators, you'll see a macrophage type class switch. So this macrophage then becomes a pro-resolution macrophage that begins the healing and repair process for tissue regeneration. And this is kind of showing in this slide some chronic inflammatory diseases. And we talked a little bit about concussions and TBIs, and we're talking about chronic illnesses. And in the case with some people with chronic stress or with trauma, PTSD is common, but cardiovascular disease, renal disease, Alzheimer's disease, these are all things that are linked with chronic inflammatory state, the inability to get into a resolution state for repair and regeneration. And this would be, this slide just kind of shows sort of an example of a chronic inflammatory state. What does that translate into when we're talking about a body? And the reason why I list this is just because this would be the antithesis of what you want to see in an athlete. You don't want to see bone mineral density loss. You don't want to see muscle loss or catabolism. You don't want endothelial dysfunction and high oxidative stress. You don't want appetite changes and accumulation of fat, accumulation or increase in acute phase reactants like C-reactive protein, insulin resistance, and erythropoietin resistance, so anemia. So this would be what you don't want to see. And these things would be linked with these cytokines. So you would have an elevation in tumor necrosis factor alpha and interleukin-6 as an example, with a decrease in interleukin-10. And when you look at SPM production on the immune system, what you'll find is that SPMs have the opposite effect. It has a tendency to do the opposite of this, or at least allow this to happen in a natural way so that healing can happen and then push into resolution so that those changes don't happen. So when we look at chronic inflammation, you're basically looking at a deficiency of the ability to produce pro-resolution mediators. And an imbalance of inflammatory mediators leads to unresolved inflammation, and it becomes chronic inflammation. And under certain circumstances or conditions, that natural capacity is lost. Again, if you're talking about autonomic nervous system function, if somebody is stuck in a sympathetic state, they're in sympathetic overdrive, they're not sleeping, they're not resting, they're anxious. These would be people that are under-recovered or overtrained, however you want to look at it. That would be a common state where you would start to see a deficiency in pro-resolution mediators. Somebody who's losing production of anabolic hormones. So if somebody doesn't have DHEA or testosterone, or in women estrogen, these are patients that would end up having sort of this chronic inflammatory state as well. So in discussing or understanding inflammation and healing, what we really have to do is change our mindset. So instead of looking at everything from the standpoint of anti-inflammatory, instead of looking at how do we get people to heal by blocking inflammation, what we have to look at is how do we get people into pro-resolution. And this goes back to what's available in, for medications for people, that anti-inflammatory treatments typically will block modulators that drive inflammation, but it also halts the process of inflammation and also halts the process of resolution at the same time. So if we're talking about pro-resolution, we're hoping for the ability to produce SPM so that we don't block the initial inflammatory phase. We allow that light bulb to be taken out before we try to shove another light bulb into that socket. So SPMs will resolve inflammation without compromising the immune response, without the risky side effects that you see with anti-inflammatory medications, and then they'll promote tissue repair and regeneration. So again, kind of discussing this, that the thought process, instead of blocking inflammation and pushing back against inflammation, we should be pushing for resolution in our athletes. We should be looking at how do we promote SPM production, how do we promote resolution, and I think we're getting better and better at looking at periodization of training and timing and regeneration days, and understanding that it's not, that if I'm not making progress as an athlete working out 2 or 3 hours a day, then I need to get 6 hours a day and push harder. That doesn't necessarily work, and I think we understand that that's the case, but understanding why that's the case, part of it is linked back with this resolution process. And if you look at efficacy of resolution mediators, and this is one of the things that I often get asked by medical staff when I'm working with the team, why can't I just have somebody eat fish? Or why can't I just give them fish oil? And you can see that there's an efficacy difference between somebody who is just eating fish and somebody who's taking high-grade fish oils, which is better, but then somebody who would be taking SPMs or pro-resolution mediators, that this is more potent in its inflammation resolution, and it's one step removed from using a drug, basically, which would be things like moresins or resolvins. If you look at how these metabolic pathways work, you'll understand that EPA and DHA are derived from alpha-linoleic acid, but you can't necessarily just give somebody flaxseed oil and see dramatic changes in their EPA and DHA levels. Most people don't do this very efficiently. It's an inefficient step for conversion. So we understand that when we're talking about brain health or we're talking about heart health, that it's better to give EPA and DHA than it is to give just flaxseed oil for these patients. The same holds true when we're talking about conversion of EPA and DHA into pro-resolution mediators, that this is a slow multi-step process. It doesn't happen quickly. It can affect SPM production, but it doesn't in everyone. So SPMs are the more efficient way to help with this resolution process. And there are some studies that look at this. And this was a study that was done in 2016, basically looking at pro-resolution mediators in inflammatory arthritis. And what they found is that there wasn't a good correlation in patients taking EPA and DHA to the SPM production or the availability of SPMs that were present in the joint. So these people were getting plenty of EPA and DHA, but they weren't necessarily able to convert it into the active form to cause resolution to be present. And this was a study that was done looking at resolution capacity, taking basically a murine model and measuring neutrophil activity. They injected lipopolysaccharides into subcutaneous tissue, measured inflammation, and then they gave SPMs orally to these animals. And at low dose, they demonstrated an activity that was superior actually to indocin as an anti-inflammatory drug. Both of them obviously were better than controls, but it's interesting that the SPMs were more effective than indocin, and really they were kind of in the ballpark of what you would see from the drug itself, moresin, which is the end state of SPM productions from DHA, at least one of the pro-resolution mediators that would be considered a drug. There is clinical evidence that looks at, and we've been looking at this for EPA and DHA, and how they affect athletes and the benefit in relation to sports and traumatic injuries. DHA helping acute exercise recovery, neuromuscular function and performance in athletes in the second study here, training and acute exercise recovery, football and North American football in preventing long-term injury from head trauma. There was some suggestion of neuroprotective effects of DHA. There's some evidence that omega-3s help with depression. And then when you're looking at exercise-induced muscle damage, the same thing, that EPA, high-dose EPA seems to be beneficial. In fact, you need PGE2, prostaglandin E2, to be produced to help with muscle recovery after exercise, which is a pro-inflammatory mediator. So you need both the normal pro-inflammatory mediators to be present, but then you need the resolution mediators to be present at the same time. And these are 3 clinical trials that have been done in humans, looking at taking pro-resolution mediators and measuring response. So this is a top left here, randomized placebo-controlled study showing that taking the SPMs increases peripheral blood specialized pro-resolution mediator concentrations, and reprogram host immune responses to get people out of that chronic inflammatory state. This one was done in the Journal of American Heart Association, and the treatment with marine oil supplement altered the lipid mediator and leukocyte phenotype in healthy patients and those with peripheral artery disease. And the bottom here, evidence of clinical response, basically, in people with chronic pain, that these patients who were taking SPMs had an improvement on their quality of life and a reduction in pain. So there are human studies, and this is another thing that I commonly get asked. When I started using these initially, there weren't a whole lot of studies that were available. I was seeing the clinical results, but people sometimes will ask, well, what are the human studies? And these are being done and shown, and they follow the pattern that we're seeing in vitro and in vivo, and what we're seeing clinically in practice. And to kind of circle back to anti-inflammatory medications and looking at SPM production, there was a good study that was done by Markworth, where they used ibuprofen. They gave these patients 600 milligrams in a day of ibuprofen, and then measured both pro-inflammatory mediators and resolution mediators, and wondering what would happen, what would the effect be of ibuprofen on muscle recovery. And basically what they found is that the ibuprofen blocked the production of pro-inflammatory mediators, which you would expect, so prostaglandins, thromboxanes, et cetera, but they also had a significant negative impact on SPM production. And so this was the first sort of proof that pro-resolution mediators were part of the recovery and healing process early on after exercise. So their findings suggested that use of anti-inflammatory interventions to enhance post-exercise recovery would be at the cost of delayed and or diminished natural resolution of the inflammatory response to exercise. So it had a negative impact, which is not surprising. Some other studies that are present looking at anti-inflammatory medications and how they have a negative impact on recovery and healing. It has a negative impact on exercise-induced muscle damage. And when you're looking at people that have like delayed onset muscular soreness or DOMS, you might help their symptoms, but you're also blunting their recovery process. You don't have as much muscle protein synthesis with this. Anti-inflammatory medications delay fracture healings. We know this to be true, although there's been some people that say that there's debate in the literature whether NSAIDs help or hurt, but all of the positive literature actually exists with the use of aspirin, which irreversibly acetylates cyclooxygenase, but pushes the production of lipoxin A, which is the one pro-resolution omega-6 converted lipid mediator. So lipoxin A then causes the lipid mediator class switch that we talked about earlier. So there may be some positive effect, but in general, anti-inflammatory medications or non-steroidal anti-inflammatory medications have a negative impact on healing. And you can see this in athletes who are chronically taking anti-inflammatory medications, and their incidence of fractures is higher and their recovery is slower. Same with musculoskeletal injuries, that we might help their symptoms and help them get onto the playing field a little bit faster, but we also slow their recovery and healing. Concussion and TBI seems to be a negative correlation with outcomes with this. And again, if you can't get into a resolution state, then you're going to have chronic long-term problems. And the worst case scenario that you would think of would be something like CTE, or Alzheimer's disease, or some sort of neurodegenerative disease, Parkinson's disease. These would be chronic inflammatory states which are associated with a lack of SPM production. So why would you want to block that and not allow that healing to take place? And this bottom one here in the British Journal of Sports Medicine, this is an older study, but they said that athletes who regularly took non-steroidal anti-inflammatory medications before exercise may have reduced tissue adaptation to prevailing loads, potentially predisposing them to future injury. NSAIDs have the potential to reduce the rate of matrix production and subsequent tissue repair following microscopic or macroscopic injury. So fits in with this pattern, and it fits with what the scientific community has been saying about how resolution mediators work. And that, again, that work was started by Dr. Sirhan in Harvard, and it's been shown to be the case when we're looking at studies. They line up and match what we're seeing in the lab studies. As far as benefits of SPM use for sports injuries and trauma, in both of these circumstances, inflammation is provoked by the injury. The injury-induced inflammation initially acts as a host defense mechanism, so it spurs the process of healing and repair of tissue, getting rid of damaged tissue. And the timing of protective function of the inflammatory response is vital, since the chronic inflammation is associated with progressive cell loss and toxicity. We don't want this to go on to become a chronic state. Endogenous SPMs represent a valuable target in shifting the balance of inflammatory processes from inflammation driving to inflammation resolving conditions. We have to think about pro-resolution rather than blocking inflammation. And dietary supplementation with SPMs does increase the availability of SPMs and helps resolve the inflammatory state after an injury naturally without blocking the normal inflammatory process. Another question that I commonly get asked is whether SPMs are safe. Are they safe? Do we normally find them in human tissue? And you can see by this diagram, they're everywhere in human tissue. You see large amounts of SPMs that are present in brain. You'll see it in breast milk and placental tissue. So it's obviously a vital part of the normal immune response, even for mothers passing it off to their children. It is obviously going to be present in lymph nodes. It's in cerebral spinal fluid. So yes, they're safe, and they don't cause an immune compromised state or block the normal immune response that you would see with taking the approach of blocking inflammation. And so I brought this slide in because over the course of a season, this is several years back, we're looking at a professional baseball pitcher who had some chronic elbow problems, some elbow pain. And this was at the beginning of the season. The top right here, you can see their EPA and DHA levels were on the lower side. We changed diet, and we started about 1 gram or 2 of the ProResolve, and then we remeasured this after about 2 months. And you can see the levels are beginning to move to the right. And then we doubled the amount. So we went to 2 grams or 4 of these ProResolve SPMs, and you can see the omega-3 levels measuring here. And on the clinical side, his elbow pain was no longer an issue through the course of the season. He did well. Pain basically resolved, and no further problems that we had to really work on other than the biomechanics and typical therapy stuff that we would do. And so what do we kind of suggest for recommended dosing with SPMs? Again, they're applicable to any condition related to chronic inflammation, but they're particularly valuable to aid in the recovery of bone and musculoskeletal injuries and neurological injuries. And what I'll typically do is for patients that have just sort of a mild ongoing inflammatory process that doesn't necessarily interfere with activity, I might just have them take 1 a day. Somebody who is more active, let's say it's a professional athlete who has some subacute problems that are going on, I might have them take 2 a day, but once they get into the state where it's starting to affect their performance a little bit, or they've had an acute injury, then I'll probably have them take about 4 of these a day. So I'll have them take 2 grams divided into 2 doses, or into BID dosing during the acute inflammatory state. And then once they're back into a state where they're feeling better and it seems like recovery is back to normal, then I'll back them off to 1 or 2 a day. When we're looking at this product, which is available, this ProResolve, it's a specialized nutritional product. I listed here off to the top left. There's a monograph if you want a more detailed information on inflammation and resolution and what pro-resolution mediators do. You can go to that website. The booth at the show will have information for you guys if you want to go look. But ProResolve is enriched inflammatory resolution activity, or SPMs, that are available in an over-the-counter supplement formula, and it helps to resolve inflammation related to injuries and trauma. They're safe, and it's standardized in production. You can see off to the left what you're going to find in these fractionated SPMs. You're going to find 18-H-EPE, 17-H-DHA, and 14-H-DHA. So you get these pro-resolution mediators, which are active themselves, but they also can be converted through your immune system into the downstream byproducts of resolvin, protectin, and moresin, which are the 3 SPMs. You would, a serving size is 2 soft gels, which would equate to 1 gram of these pro-resolution mediators. So this product has been available since 2018. I've been using it in the populations that I work with, which is high performers and professional athletes, and I work a lot with the veteran community in the US. We have a lot of people after the prolonged war on terror. We have a lot of people with chronic injuries, and this has been sort of a mainstay of helping these patients.